to the City Club of Portland's Friday Forum. I'm Courtney Nelson, President of City Club. For 100 years, City Club of Portland is where civic-minded people come together to make Portland and Oregon a better place for everyone to live, work, and explore. We're gathered at the Sentinel Hotel today, along with all of you listening on OPB Radio or viewing on Portland Community Media or YouTube. The generous support of City Club's corporate and media sponsors enables us to put on the state's best civic programs week after week. Our media partner is Oregon Business Magazine, and our current Friday Forum sponsors for the fall are Avangrid Renewables, Airbnb, McKinley Irvin, AARP, and Uber. We also have a program sponsor today of Oregon Physicians for a national healthcare program. Please join me in showing our appreciation. And now onto our forum. Our topic today is what can other nations teach Oregon about healthcare? Like all states, Oregon struggles to provide better healthcare to more people for less money. While much of what we are trying to do is unproven, there are opportunities for learning from other nations who have found both successes and failures with different healthcare models. Our guests today are Dr. Kieke Okma, visiting professor of international healthcare at McGill University. She has worked on healthcare issues with government agencies, universities, and international organizations, including the World Bank, for over 25 years. Born in Amsterdam, she now lives in New York and works as an academic and international health consultant. Dr. Ted Marmor is a professor emeritus of the Yale University School of Management. Dr. Marmor has written and presented extensively on Social Security, healthcare policy, and healthcare reform ever since his participation in the creation of Medicare in 1965 as the aide to the Secretary of Health, Education, and Welfare. Our moderator today is Serena Cruz, the Executive Director of Virginia Garcia Memorial Foundation, where she works closely with the Virginia Garcia Memorial Health Center. Previously, she served as two-term Multnomah County Commissioner, where she worked on healthcare access for the uninsured, housing for homeless families, and sustainable answers to transportation challenges. Please welcome our moderator and panelists to the stage today.
Thank you, Courtney, and good afternoon, everyone. It's truly my pleasure to be joining you with Ted and Kieke here today to have a conversation about what we can learn in Oregon, and clearly there is much for us to learn. I would like us to start out with just a brief description of what you hope to, how you'd like to frame the conversation today for each of you, to take just a couple minutes to do that. Kieke, would you like to go first?
Well, the one exciting thing of being in a city club is our experience that so many people have a very keen interest in issues of healthcare and are interested in international experience, but we have little access to that information, what happens in other countries. And second, if we read about other countries in our newspapers or the news, it's often very biased or misrepresented. I'll just give you one example. Very often, if people talk about healthcare in Europe, they talk about government-run socialized medicine, right? Wrong, it doesn't exist in Europe, so I'll come back to that.
Okay.
Well, I've been thinking quite a bit about what to say in 2 minutes that might engage you and not be misleading, and here it would be. I'm going to try today in the answers to questions that are posed to reflect and comment upon what I take to be the confusing and in some ways incoherent debate in the United States about healthcare, its financing, its distribution, and its regulation. And the way I want to do it is with 5 principles that are at stake in any healthcare discussion, but are not very well discussed, in my view, in the United States. 1, I want to talk about in what sense people use the term and debate universal coverage. That's number one. Number two, I want to pay attention to what it means to talk about comprehensive benefits. What is that about? Number three, I'm concerned about what is meant when people talk about accessibility to medical care. Both talk about it and confuse people about it. And the distinction, for example, between accessibility to financial protection from the cost of medical care as opposed to access to medical care, not the same thing. A fourth element is to what extent is the coverage that someone has for financing medical care portable across state lines, let alone across national lines. It makes a big difference if it doesn't cover you except in your residential side. And finally, and very importantly in my view, to what extent does the proposal for healthcare reform or the proposition of contemporary healthcare reform offer an avenue of public accountability for the performance of medical care? That's ambitious, these five, and those were the themes that I'll try to turn to.
Perfect, perfect. Well, in Oregon, we like to think, I think frequently, that the Affordable Care Act made access to, solved all of our problems for health care. And out in Washington County and Yamhill County, Virginia Garcia really grew as a result of the Affordable Care Act, going from serving 30,000 patients to 45,000 patients, but still 20% of our patients remain uncovered. Could you speak to universal care and why universal care is such an important concept for us to really understand what we're missing here in Oregon and the United States?
For me, is that turned
Go
to me
for
first?
it, Ted, and then Kieke.
Well, the first thing to notice is that the Obama reform, or the ACA, did not provide access to care. It provided access to insurance. More importantly, the insurance it provided, and you should concede right at the outset that the difference between no insurance and some insurance is very important. But as soon as you turn to the question of what kind of coverage, notice that you have these various bronze, silver, other kinds of levels of insurance, and the degree of financial protection provided is enormously varied. And what I would call attention to is the difference between that conception of entitlement to some insurance as opposed to entitlement to coverage of the care and costs that you incur. And so if you think about north of the border, one of the principles in the Canada Health Act is accessibility. And accessibility there means no financial barriers to care. And judged by that criterion, the ACA falls far short. Judged by the criterion, are 20 to 25 million Americans better off having some coverage? I think the answer is yes. But it's coverage a long way than what would be recognizable to either our Canadian neighbors or our distant neighbors in Australia, let alone citizens in European countries.
Kieke, could you speak to the European experience or other countries beyond Canada about why this premise of universal care is so broadly held?
Well, let me limit myself to Europe. That's already a handful of about 50 different countries that are more diverse than even the state of the United States. One of the interesting things in Europe is that we have had universal coverage for such a long time that the current generation of young Europeans almost forget how important it is. However, what is very important and very dominant across Europe is how strong the popular feeling is that governments are responsible to make sure there is universal access to healthcare. This strong value is extraordinarily strong. So whatever happens, governments are held accountable. So that's a very strong sense based on the experience. And the experiences were twofold, the major two sources. The one was the German model in the late 19th century. After Bismarck unified Germany, he figured out a way to bring in the as a pre-exemptive strike against the labor movement, the unrest, he figured out social insurances, and in particular, social health insurance. What did he do? He didn't replace the existing local mutual private health insurance schemes, the non-profit ones. He left them in place, but he made membership mandatory. So what was the model of the social insurance? Mandatory membership for all industrial workers that allowed those little schemes to become bigger in their scale-up operations with decentralized administration under centralized rules. And those centralized rules, that model is still in place today, imposed standardization on the whole country. Standardization in fee schedules, standardization in reimbursement fees and administrative rules. That means very low administrative cost, very high degree of transparency. That's the German model, still in place, the continental European model. After the Second World War, England followed and thought, well, rather than limiting ourselves to industrial workers and other groups, why not make that universal, 100% of population? After all, they had gone through the war, upstairs and downstairs classes had met each other in the subway during the bombardments, or they shipped their kids out to the countryside during the war. So they felt, if we need health insurance, our cleaning lady needs that too. So that sense of universality was fueled by the war experience itself and enabled Churchill, like Bismarck have a century ago, conservative politicians, no bleeding heart liberals, but conservative politicians who acted on a combination of social concern and self-interest. We better make sure the population is insured. And in the UK, they went a step further than Germany, said we make it 100% universal coverage, so we don't need those individual agencies. We have central administration, top-down. England nationalized hospitals. Germany never did that. Germany had a long tradition of not-for-profit hospitals, still today, dominant. England left the GPs outside. Those GPs were too unruly. They didn't want to join the fun, so they never succeeded in bringing the general practitioners into the NHS. But the hospital system was basically the model of socialized medicine. However, a couple of decades later, they thought, well, too much hassle for government, and there was more of a conservative government. They pushed hospitals back to their original legal status of independent hospitals, not-for-profit independent hospitals. So that's dominant across Europe. We have financing side, collective financing through taxation, through social insurance, but not collective provision of healthcare.
Perfect. And I look forward to getting more into the financial aspects in a few minutes. For those of you listening on OPB, this is City Club of Portland's Friday Forum. I'm Serena Cruz, the Executive Director of the Virginia Garcia Memorial Foundation. Today we're talking healthcare with Dr. Kieke Okma, Visiting Professor of International Healthcare at McGill University, and Dr. Ted Marmor, Professor Emeritus of the Yale University School of Management. So now let's move on to a little bit of a different topic. I think frequently when folks hear universal care in this country, they think single payer. And one of the interesting things that both of you have explored in your research is the delivery of universal care through private means. Could you speak to that, each of you?
Well, private means can mean many different things, so let's try to be clear about that. If you want the most clear example of not using private means, you would go to Canada. And you would go to Canada, you would discover that all citizens in Canada and all legal residents are eligible for a single plan for hospital and physician coverage. So the people who supply the services, both at the physician level and the hospital level, are not civil servants, but they are, in the case of doctors, private professionals who engage in agreements with the government of each province about their fees and about their extent of their utilization. Very complicated in some sense and very simple in another. On the other hand, if there's a much more controversial aspect of where private provision and public provision are available to the same hospitals and physicians. Let me illustrate that. In England, consultants make contracts with local health authorities for some proportion of their working week. 9/11 was the case some years ago. But in the 2/11 that are left, they're free to provide care to others who buy private insurance to cover the extra payments that are made here. And that's an example of private provision that permits jumping the queue for the very doctors who are spending 9/11 in one place and 2/11 in the other. It's important for you to know that the argument in Canada is that if you permit private insurance for publicly financed care, that means you're violating the principle of access according to ability to benefit and according to medical need. We have not had in our conversation in the United States in the years since 2008, when the issue of healthcare reform began to be so serious, we've never had a debate which sharply distinguished, and I'll only make this one last point, Serena. We've never had one that sharply distinguished between allocating access to medical care according to ordinary market criteria. What does that mean? It means according to ability and willingness to pay, as opposed to another set of criteria, which is ability to benefit and seriousness of need. Those are the dichotomous choices available in a serious debate about medical care. And you give me one example. I shouldn't be so professorially challenging here. I'm in a different context. Think about an example over the last, 8 years of a speech that you heard which made that distinction. And I dare say it would be hard to find it. In short, we've never had a fundamental understanding or debate about what it means to allocate by private market as opposed to non-private market criteria.
Maybe I can follow up on that with some of the international experience. There are basically about 6 countries in the world that have tried to introduce or expand the role of private health insurance as a major source of healthcare finance. Chile, the Netherlands, Germany, Australia, the UK, in different forms. Some were supplemental, some were double of the existing ones. Some cases, like the Netherlands and Switzerland, tried to replace existing schemes with private health insurance. And what's striking across all those nations is the similarity of the problems that arose from that shift. The one is, the first extraordinarily predictable shift is that the persons who will go to the private sector, who are they? Well, who are they? And wealthy and healthy and young. There you are. And the elderly people who may have chronic illness or the low-income families cannot go to that market because they're not so welcome. That's a problem. If your policy goal is to reach universal health care and you want to use private health insurance, you need a lot of regulation to overcome that access barrier. That's very difficult. And then we found that the other problem is our children, our grandchildren, the 20, 30 years old, they're the invincibles. They think they will not be sick. So if it's voluntary, they won't take health insurance, or they think it's too expensive. So that's another problem. If you don't make it mandatory, Bismarck already understood it. You have to make it mandatory because you need a big risk pool that includes the sick and the healthy, the young and the old, the rich and the old, and the poor. So having broad risk pools is very important. Maybe not 100% of the population, but big risk pools, not small ones. That's a very important one of the international experience. And the other one I briefly mentioned is we have to think about how to standardize stuff. Why do we have all those enormous amounts of administrative people running the show? One of the docs told me in his office they had 6 administrative staff on one doctor. In Amsterdam, we had one administrative staff who also doubles as the physician assistant for one physician. There's waste for you.
Kieke, that's a perfect place to go. Let's talk for a moment about the private delivery of care in this country and how we, as Americans, believe that we deliver things in the most efficient means possible, and yet there are barriers in this market, the healthcare market, that make it costly. And I think you've touched on some of those administrative costs. But in comparison to countries where there is universal care, are they spending more or less than we are, and what type of care are they getting?
That's the easiest question to possibly answer.
Had to give you a simple one.
We call that in baseball and in academic life a softball. The United States is spending a lot of money on medical care, more than anybody else in the world. As a justification, some people claim we have available the best medical care in the world. And in some sectors, it's surely true that we have a level of skill and competence that others would be jealous of. But the distribution of medical care burdens and the overall expenditures for medical care are extraordinarily more expensive. One way to put it in perspective is if you went back to 1970 and asked, how much did America spend on medical care as part of national income, and how much, let's say, Canada spent at that time, to use that example, we both were spending almost exactly the same amount of money as a proportion of our national income, about 7%. By 1980, Canada was spending about 8%, and the United States was spending closer to 10%. And by 1990, it was 11 versus 9. By 2000, it was 14 versus 10. And by 2010, it was 18% versus 10%. In short, there was a huge gap that was built up. And here I would mention two things and stop. One is that the question of what that money bought is surrounded with mythology. Sometimes people think it bought a lot more care. Not true. What it bought was the same, roughly speaking, distribution of care at higher prices. In other words, Americans pay more for the range of care that goes elsewhere that's paid less for. Some of it administrative, but some of it just in terms of prices. And of course, the best illustration today would be the price of drugs, in which we pay much more than other countries do for drugs, because we bargain directly. There's somebody on the other side of a monopoly, but I'll stop there.
Fantastic. And before I turn it back to you, Kieke, to address that question, for those of you listening on OPB, this is City Club of Portland's Friday Forum. I'm Serena Cruz, the Executive Director of the Virginia Garcia Memorial Foundation. Today we're here talking healthcare with Dr. Kieke Okma, Visiting Professor of International Healthcare at McGill University, and Dr. Ted Marmor, Professor Emeritus of the Yale University School of Management. So, Kieke, if you could pick us back up on this concept of cost in the United States versus cost in other countries, what would you want to share with our audience?
One of the most alien parts of the effective cost control strategies in Europe, and one of the most important one, is the notion of collective bargaining. The tradition that traces back to the 19th century, in which but has been spreading all over the social health insurance model, where the third payers, the payers on behalf of all of us, the insurance agencies, public ones, private ones, and government agencies, who are sitting at a table together with the representatives of hospitals, docs, other health professionals, to bargain over the allocation of the available resources. First, they have some political agreement over total spending. That's another alien idea in the United States, but we first have an idea we do not want to spend more than maybe 10, maybe 12% of GDP. That's a starting point. And that translates in Germany, for example, or in Canada, in regional budgets, spending targets, political budgets, as it were. And then the parties sit at a table and say, how are we going to allocate that money? Very effective instrument because everybody is engaged in that discussion. If you don't have that, it's hard. You have to impose it in a one-sided way, and you don't have all the parties who will listen to that idea. So that was one. The other part, as I mentioned, is the standardization of rules and forms and entitlements. Like the best example in the world, basically, is the American Veterans Health Administration. It's extraordinarily efficient. Has its problem. Every big system in the world has its big problems, but it is extraordinarily transparent and efficient in its administration.
Ted, did you want to add something?
Could I just add one point to the discussion of cost? And the way I would put it is that it is simply the case that cost control, or the control of costs of medical care, is everywhere in the world a controversial matter. There's no escaping it. And the reason there's no escaping controversiality is very simple. One is an accounting identity. A dollar of expenditure must be a dollar of somebody's income. Now go to the next level. If in the nation or in the state, the expenditures of state expenditures must be the income of people operating in the state as providers of services. And to control the costs rising less rapidly than it would have done otherwise means that someone's income has to be less than it would have been otherwise. And for that reason, you can never arrive at some easy stasis. I don't care how much talk about prevention can take place. If what's prevented reduces the income of the service provider and there's a substitute activity, costs have not been reduced, but some prevention has been done. Anyway, that's the point that I want to emphasize as fundamental.
Well, that's excellent and a little depressing. So, because I want to think about solutions, but for now, why don't we focus a little bit on where you were taking us? I think some prevention and some quality of care. I took my daughter to the pediatrician this morning. She's 9 years old, and even though we've been seeing this particular provider for 3 years, we are sitting in the waiting room, and she says, "Mom, why did we have to switch providers again? Can you remind me why I can't have the doctor who visited me in the hospital anymore?" And I had to share with her, well, remember, I took this job, and with this job, I had to switch healthcare. Can you talk about provider networks and their impact on quality of care and how other nations are addressing what we're dealing with in provider networks? Does that make sense?
It makes lots of sense, but whether we can do it in 2 minutes is quite a different matter.
I'm getting worried here that the optimism linked to notions of universal coverage is that it will allow us free access to everybody is a little bit promising too much. You have to be aware of that. There is no healthcare system in the world that does not ration care one way or another. Rationing is there, but it's just a matter how we ration. By our wallet, by waiting lists, by triage, or all healthcare systems in the world are facing some scarcities, and there is some rationing going. In the US, we have still 30 million people without health insurance, and they're out of it, so their wait list is very long in general, unless Serena is willing to step in. So it's not as if other systems do not have some limits on access to healthcare, but how fair it is, how balanced it is, how it doesn't create undue barriers. And there we see that in most European countries, the common assumption is the basic medical care is basically without undue barriers. And if it imposes too much cost, for example, if we have been playing around with co-pays for certain drugs or for this or that and the other, and soon enough the parliament will say, we don't like that, it's too expensive for grandma, and we immediately introduce some exemptions to those particular co-payments to exempt the groups that are hurt hardest. So it works out even if there are some barriers, some X barriers. 2 years ago, the Senate in the Netherlands threw out legislation that would allow insurers to limit their contracting. They say we don't want that, everyone should have free access to GPs, although in practice we stay with our GPs all our lives, so it's a bit of an empty open access, but still we live with it within reason. If you have fair access and a reasonable allocation, you have a sense that everyone has the same and equal treatment, we do live with some limits. And don't overpromise yourself that we will get free access for all to the whole care in the whole world. That's too much.
That's an excellent point, and I think I was really trying to get at the artificial structure of provider networks, but I think you're absolutely right. I think sometimes we're over-optimistic as Americans and believe that if we had this, we would have access to everything. Ted, did you want to?
I want to answer your daughter's question. What about networks? It used to be the case in the United States, certainly was when I was involved in Medicare's origins, that Americans took very seriously freedom of choice of physician or hospital or caregiver. What your daughter pointed out is how much has changed over time. Ironically, limitations on freedom of choice through financial intermediaries who are private. That is, selective contracting with physicians and extra billing when you go outside the network is a way of restraining outlays on the part of health plans. It's a longer story, but the answer to your daughter is, to the extent work-related health insurance is what people use, the insurers contracting with those firms are imposing costs, restraints on choice of care. And finally, and very, I think, importantly, American physicians are the most heavily regulated physicians in the OECD world. But the people who regulate them most are insurance executives and their staff, not the government. It is extraordinary the degree to which physicians have been living with increasing restraints on their choices about what care and with whom. It's a topic that maybe we'll come to in Q&A.
Or right now, I think that's an excellent place to go. Actually, regulation, and you were pointing out that in the United States we're over-regulating doctors through insurance companies, but how are what are the differences in the regulatory environment in other countries?
Well, Kieke will have views about that, but let me just quickly say, again, going back to my Canadian example, which was the geographic area that I was to cover, Canadian citizens would be appalled at the role of private insurance in the United States. They may not be able to find a GP. That would be a different kind of problem. But if they got one, nobody would be telling them to go to somebody else. And I think it's just utterly ironic that in the land of the free, we actually have gotten huge constraints on where you can go. I'm now, as you can probably tell, eligible for Medicare. Actually, I've been using it for a decade, so candor requires. And even on Medicare, which had absolute freedom of choice of physician in Part B at the outset, even there's an analogous form of restraint or selective contracting by the way in which payments are affected by whether or not the doctor has accepted the list. We could go on with that.
Maybe I can add to that. If you look across Europe, there's an interesting trade-off almost, that the doctors who have the greatest degree of professional autonomy may be the ones who have lost their independence as self-employed businessmen. There's a trade-off. You want to be an independent businessman, you're facing the need to contract with all sorts of financing agencies, with private health insurance, with social health insurance, government agencies. However, in Scandinavia in the 1970s, countries decided docs should be employed. It's easier for all of us. Of course, in the beginning there were big fights, big battles, but they've grown over it. And actually the majority of physicians are pretty happy with that. They're employed, they get a decent income, they are the notables, local notables, as you all are as docs in this small town, and they do not have any administrative hassle. It means that more women can be doctors and work part-time if they want to. It means that although they don't need to work part-time because childcare is so much better there, it means that they have their professional freedom. And maybe they don't earn $2 million, but they don't need to because sending kids to college is not expensive as it is in the United States. And they don't have litigation because we don't have the tradition of litigation so much. So you have to think about what makes the position of doctors attractive. It's not just the income level, it's also do they feel respected, like all of us like to do? Do they feel they have professional autonomy, like all of us would like to have? And that's very interesting. The countries who do best on that scale are not the ones who let doctors set up private clinics at all. There's a restriction there. So the restrictions are totally different. We've here let docs turn their business into a private business, as it were, and then they're facing this idiotic scale of private regulation Ted referred to.
That's great. It looks like we have about time for one more question among us. And one of the things that we're focused on at Virginia Garcia is the relationship between payment methodologies and the kind of how it correlates with the philosophy of care. So we were in a fee-for-service environment, so every time you got to see the doc, we were able to bill for that. And now we're in a capitated capitated, where we get a per member per month, and so we're able to provide full primary care and dental care to members based on that. Do you see an impact, or do you think we're going somewhat in the right direction with a step toward capitated care?
This better be the last question, because I'm going to get into trouble here, I think. The point that I would make, Serena, is that there is no self-regulating, wonderful way of paying physicians or anybody else. Every method of paying has the vice of its virtue. If you pay fee-for-service, you get more services, maybe too much. If you pay capitation, you tend to get long capitation lists, which gets in the way of the time of physicians. And if you pay by salary or sessional payments, the danger is nothing will get done. It's the downside. Freeing up the professional, as for example a professor, is the most wonderful thing in the world, and yet you've got worries about people doing too much consulting and something else. So I think the important point to draw, although we haven't had much discussion of it, is the dangers of believing in reform of payment methods as a kind of panacea. There is no panacea, and you need to be worrying. One, you need to be worrying about the danger of anyone you're using, and secondly, cross-nationally, it is simply the case that mixed methods of payment are popping up everywhere. There's a variety of starting points, but all the rich democracies are having elements. When you want vaccinations, fee-for-service makes lots of sense. When you want people to be worried about long-term care and chronic illness, that's a very different situation. The point here is that we can learn from the reality across many different systems that the United States will not figure out a panacea.
Got it. Anything to add, Kieke?
One point I want to add is it's not just only that we all have developed mixes of payments, we all are adjusting that all the time. Because, for example, the example Ted just gave about giving docs extra money for flu vaccinations may encourage doctors to send out emails to all their patients to get flu vaccinations twice a year, and all of a sudden we think, oops, that's a lot of money going out of the door. Or so we may have been overdoing that. And the latest fashion on the block is this so-called P for performance, P for P. This I have sometimes labeled that the pissing contest of payment. But that's an idea that if only pay for performance, docs will do what we want them to do, which is idiotic. But we embrace fashions, we try them out, and it's in Britain or in the Netherlands we found all of a sudden the GPs in those two countries are the highest paid in the world. So something went wrong, how rapidly they saw their income increase. So we always have to tweak and twist and adjust those payments, methods and mixes.
Fantastic, thank you. For those of you listening on OPB, this is City Club of Portland's Friday Forum. I'm Serena Cruz, Executive Director of the Virginia Garcia Memorial Foundation, and today we're talking healthcare with Dr. Kieke Okma, Visiting Professor of International Healthcare from McGill University, and Dr. Ted Marmor, Professor Emeritus of the Yale University School of Management. And now it is time to open the floor to questions. So as a reminder, I want to please ask the questions at the microphone if you're a City Club member. And if you're not a member, please write your question on the index card and hold it up. And one of the fantastic City Club staff will come around to get it from you. And I will try to ask at least one question from an index card. So please, sir.
My name is Richard York, and I am a City Club member. And I want to thank all three of you for being here and giving us your time and information. In my 70-plus years in this country, I have watched us develop the least effective, least efficient, most expensive healthcare system in the industrialized world. One of the key reasons for this is that the American people have been subject to a constant litany of misleading information, lies, and lies about both our system and that of other industrialized countries. It's coming. What I want to know is, how can we change this kind of propaganda and get to the American people the truth about what kind of a system we have and what kind of a system the rest of the world has?
No, I'm going to take that question very seriously, but answer it seriously too, which is, if I knew the answer to that question that you posed, how to get truth told about other systems and how to punish untruths told about our system, I wouldn't be here before you. I'd be working in that system already. But I think what you can say on the basis of that question that I hope will be helpful is to acknowledge three things. One, that interest groups everywhere in the world are concerned about the interests of their members. There's no wonderful state of affairs where the doctors agreed gracefully to come under universal health insurance schemes. In most Western industrial countries, there was a huge fight, and there certainly was one in Canada with a strike in Saskatchewan. So that's point number one. There's not nirvana someplace else about truth-telling. Secondly, some of the reason, in fact, a good deal of the explanation for our disappointing capacity to have a sequence of reforms that make us more satisfied rather than less satisfied over time, have to do with the institutions of American government. Our political system is organized in such a way as to make substantial reform of anything very difficult. We've got a dispersed political order. Our elections don't settle what we can do. And the difference between Canada and the United States is not ideology. Canadians are more like the United States than any other two countries in the world, except maybe Norway and Sweden. The difference is Canada had a parliamentary system, and in the 1950s and 60s, they went to universal hospital insurance. We, with similar arguments, enacted Medicare in 1965 and added parts to that, but never made the next step. So Medicare for all was a conception, a vision that was actually worked out in Canada, and we didn't. So I would say the only way to think about this happening is the production of either one step at a time towards a better system or an avalanche politically that shifts the political power, as happened in 1964, for example.
Thank you. Let's try to get to another question. Thank you.
Yeah, Tom Hamilton, City Club member. My question is, in the United States, pricing is largely set in the private sector for medical care. Is there anywhere else in the world, and we pay the highest in the world, is there anywhere else in the world that relies on the private sector to set prices?
Roughly, no.
Well, In the industrialized world, roughly no, but still there are substantial parts of medical care, for example, prescription drugs or medical devices, long-term care, where markets are pretty dominant in a lot of price setting or volume capacity determination, but still in most countries there is some degree of government control. For example, patient protection, safety concerns, and the quality control. So it's still in the public domain more or less, and importantly seen as a government responsibility. But for the rest of the world, if you look at the big countries of India, China, or developing countries, it's much more of a private market. The poorer countries are, the higher the share of out-of-pocket payments are for the country as a whole, and within the countries, the poorer people are, the more they pay out-of-pocket directly for anything they need in medical care.
Thank you. Bill?
Bill Dickey, City Club member. One of the problems with this topic is that everybody has anecdotal experience with the issue. My question would be, what happens to our system if we just lob off the insurance companies altogether? Just eliminate that part of the budget and say, no more insurance companies for healthcare, cars, homes, whatever, but no more insurance companies in healthcare. What does that do to our expense?
That's a good question and a hard question to answer precisely. But roughly speaking, the estimates are that the administrative costs of working with the many different Americas, a big part of it involving private insurance through the work world, let alone private insurance in Medicare or Medicaid. The best, or not the best, but the most common estimates are that we're spending something between 15 and 20% of the total $3 trillion of our budget, both in the offices and hospitals to deal with it, and also on the patient side in getting intervention. So if by some magic we could become Canadians for the moment, we would have outlays closer to the Canadians, but not equal to them, because they spend less on administration, but they also have lower prices per activity. That is an indisputable part of the difference.
Okay, and if we could just give you guys one, great. I want to take one of the questions that was turned in, and it's because there were a few of them regarding social determinants of health. So what can the U.S. learn from other countries regarding the health system's role in addressing social determinants of health, and specifically integrating community-based social services, affordable housing, that whole big scheme of things that we know affect probably about 80% of somebody's health?
Well, I think the most important lesson of the social determinants of health discussion is choose your parents carefully. That's the genetic trumps all. I mean, but second, then apart from that, living conditions, environment, working conditions, all of that's important. What do we do in our schools? How do we feed our kids in schools? And it's more of a social concern. It's not directly health policies. It links to health policy, but it's a concern for all of us. Portland's a wonderful city. If you come from Amsterdam, I really feel at home. There's bicycle trails, and people are pretty outdoorsy, and it rains all the time. It's really nice to be here. So so you can do a lot of things to try to engage people in a healthier lifestyle and all of that. But there is so much that we really can do, because in the end, it's hard as governments to say you stop drinking and eating so much, and now the battle about fat is starting to go and enter our restaurant and our private lives. And do we like that? Are we going to change our lifestyle? So it's very difficult to change that. We know what it is, but to change people's habits is not very easy. But the other ones you mentioned, public transportation and housing, sure, are important too. But it's all the domains We know a lot about it, that how much are those determinants of health important to our healthy lives, but they're not easy to solve. This is a huge country, and you travel around in Oregon, as we've done a little bit. I mean, it's beautiful, but you also see there are pockets of poverty, poor housing, very remote access, difficult access to good education, so not easy to solve.
Well, the point that I would make is that health promotion and the promotion of the health of the population is an utterly admirable aspiration, but it is not and cannot be the focal point of medical care arrangements. Medicine and medical care is about dealing with sick people and trouble and victims of accidents. And there's no system in the world that's made a huge difference in the health of populations through the medical care system. They've done it through a combination of attending to school, attending to accidents, not through medical care. It may not be tolerable for those who are committed to the health promotion sector, but I can tell you, I'll leave you with this fact. In 1974, the Minister of Health in Canada, Marc Lalonde, produced and distributed a report that was entitled, it was entitled, I used to remember it, but the topic was what could make a difference in the health of Canadians. And he made two propositions in a report that became the most widely distributed report in Canadian public history. And the claim was, number one, Canada has done about as much as could be done to make the financing and access to medical care fair and available. Big new changes in life expectancy or the control of circumstances of accident were not likely to happen in Canadian medical care. But he went on to say, that doesn't mean that we can't do anything about the health of the population, and he identified genetics, the world of work, and the environment as the three big areas where returns would be great if we made efforts to it. But notice, the three he gave had nothing to do with doctors and hospitals. And the point I'm trying to make, which I know cuts against the aspirations for a broader conception of the role of healthcare and health promotion, but I leave you with that thought.
Yes, that definitely prompts later conversation because, you know, at Virginia Garcia, we believe in wellness, and we've got Zumba and Tai Chi classes and mental health components and all of that. So we will have a further discussion about that later. Another question?
Thank you both. Anthony Petchel, City Club member with Reach Community Development. We're an affordable housing provider. My question is around social services, and in the United States, a majority of our social services are provided by nonprofits, NGOs, and funded through private donations. Could you speak to how other countries fund their social services and the effects that that then has on the healthcare system?
I think that there's a striking difference between Western Europe and this country in that regard. At the financing side, the provision in Western Europe also has been mostly based on private, not-for-profit, legally independent agencies. The financing has shifted increasingly, if not exclusively, to the public domain. So tax financing is the major funding stream for all of our range of social services. And the responsibility for social services generally across Europe has been shifting down from central governments to regional and local governments. For example, in Denmark, care for elderly citizens include housing, transportation, but also home care and medical care. If grandma is hospitalized and she does not go back to their home because there's no good home care, the city, the local community faces the cost of excess hospitalization. So that's a very strong incentive to make sure there's good home care. And moreover, there are citizen councils of elderly looking over the shoulder of local politicians, whether they like what they're doing. So there's a close collaboration between the medical services and the social services. And I think I disagree with Ted on this point. I do feel that social services are becoming more and more integrated with medical care, because though we need that range of services. Who cares whether we label it medical care or social care? We think of our own elderly parents or aging grandparents. What they need is step by step more external support, and it could be gardening or walking a dog or filling in tax returns, and then it becomes their cleaning of our house, and then it becomes personal care, and on top of that then we need nursing care and medical care, and that range is not very neat. It's messy and it's complicated, and we need to find our way around, and that's not limited to this country. That's the same all over. So it's the way how we organize it, how we force the different services to work, to collaborate. That may be different across countries.
That makes sense to me. But Ted, I know you want to say one thing really briefly, and then we'll take this next question. No, you ready? Okay. Let's take.
Hello, I'm Silvio Gurdian, City Club member and a physician in your community. I once had a practice in the state of Washington that went bankrupt due to the changes in healthcare reimbursements. We simply could not keep up with the rate of inflation. So my question to you is, how do we provide universal health care to all Americans and at the same time prevent the healthcare providers from going under?
Well, there's no simple answer to that question because that depends on how the practice is actually operated and whether they're have a capacity to adjust to budgets that are set. The only thing I can say is this. Go back to the answer I gave earlier about $1 of expenditure is $1 of someone's income. There is no magic about affordability. Affordability is a question of what funds can be raised, whether public or private. And if just the way the university that I was in responded to the 2008 financial catastrophe, the president sent us all a note saying our budget has gone berserk on the revenue side because of the shock of the stock market, and there'll be no raises at all, any part of the university. I don't think that's a very pleasant way to operate. Everybody knows it's not pleasant, but everybody also knew that it was necessary. So if your point is that the rates of payment under Medicaid or under Medicare seem low by comparison to the rates of payment by some of the insurance agencies, the answer will have to be that you have to organize your delivery of care to operate within the context of the available funds, or reduce the expenses in your practice so that you can live with those funds. It's nothing magical about it, and it's, if I'm correct, that the reason we differ from the rest of the industrial world in expenditures is that we pay higher prices for all the care that we deliver. That means there ought to be some care that is going to be reduced. And the most obvious source of that is on the pharmaceutical industry. The pharmaceutical industry has increased prices dramatically, even over the last 2 years. And we know that the use of monopoly power, which is what a patent is, has been used and abused much of the time. And the lesson we can learn is the only way to deal with that is to put someone on the other side of the bargaining that can do something about it.
I'd like to add to a point. Was your practice a family practice or GRM, or what sort of practice was that? Ophthalmology. So it's more for a specialty. But if you think those private practices, the independent practices of family practice or one or small practices, if you, for a moment, imagine you would practice in Europe, you would need one person for the administration, for the 3 docs who are in your practice, because the administration is standardized. You either have one payer, the external in Canada, the province would be your payer for all your patients, or as the case in Germany, you would have a couple of sick funds, the regional sick funds of that state, and maybe 1 or 2 private insurers, but they would have standardized administration. Reimbursement forms would be identical and automated. It means that all of a sudden your administrative cost would go down dramatically. And nothing else would have changed, and that would already one step into a direction that is hard to imagine. It's not easy to get there, but that's one of the very striking differences between most European countries and North America, particularly the United States.
Thank you so much, Kieke, and I think we're getting the signal that it's time to wrap up. Really appreciate Ted and Kieke, and it's my honor to join you all today. So thank you, Courtney.
Thank you to everyone in the room for joining us today, and to our great panelists. This is a very interesting conversation. If this inspired you to join City Club, those people who raised their hands in the beginning, you can do so in the back. Again, I'm Courtney Nelson, president of City Club. Big thanks to Sam Metz at the Friday Forum Committee, and hope to see you next week for the gubernatorial debate. We're adjourned. Thank you.